across hospitals. I'm sure there's some people in the room that want to share in this space as well, but I think one of the things that this young lady up the back here sort of said was really pivotal is that engaging the patient is really important to understand their cultural context. That is without saying. Because if you go to, and I'll be the first one to put my hand up and say, I'm not from this country, I have an affiliation with other Aboriginal people and country, but am I the expert in that space? No, not for that individual, I'm not. So we need to be mindful of those things. And there'll be any one, if you go to any one of the Aboriginal people, they'll give you possibly a different context. So using an Aboriginal person is great as a means, but the most important person in the room is that patient and how you engage that patient to get the best outcomes within the cultural context to them. So then if you do that, you'll actually get a better understanding whether it's a man or a woman as to what's required. And then once again, identifying a key person from that individual's perspective is another thing that you will need to do. And I have every confidence, because I've seen it for a number of years now, that there is some fantastic non-Aboriginal clinicians that actually engage Aboriginal people so effectively. The Aboriginal person, when they come into that space, they know that they're there for their clinical care, and in most parts they're actually more than willing to participate actively as long as they're informed and as long as they're kept informed and they understand what's actually happening. And so there's some really key things that we all need to be mindful of. Just as an example, I walked into one of the wards. I don't actually attend patients as such, but we've got, we might have some critical situations that take place, and I'll actually go along and advocate for the patient if they can't pick up another Aboriginal person. But was I the most important person in that room? It sort of, as it unravelled, it wasn't necessarily... the non-Aboriginal clinician thought that I was the most important person, and as it unravelled, I wasn't the most important person to actually achieve the best outcome from that individual. It really just, I think what it was it taking a little bit of confidence that I, in my encouraging the individual that they could actually engage this person to get the best outcome. So I think that, about building capacity, it's important for us to do that as Aboriginal people, but giving non-Aboriginal people confidence that they actually are the right people as long as they do their business in a way that actually gets the best outcome.
Yep.
Because you'll never get from me or most other people, you'll never get the most intimate detail as much as you probably like it, because we don't do it either. What is men's and women's business defined to you? Because it's not discussed. We never discuss it. We know that as far as our cultural protocols go and our practice, is that there's certain things that we will and we won't discuss. But in working with patients, we know where we need to go to get the best outcome clinically.
Yep.
Yeah, your knowledge on the ball there. It's about, we talk about people from different cultures coming to a hospital setting. How would you treat someone from another different culture in relation to understanding their actual cultural needs and their practices? Aboriginal people from all over Australia have different cultural practices. What we need to do is not so much understand those, but just be aware that they're there. But treat the individual as a human being and respect and build that rapport and work through the process with them. Work with Aboriginal health liaison officers within the hospital setting based on the individual and the orientation of the individual's preferences, to make sure that you be respectful and have people in there. Just do it respectfully and work with people in the way you'd work with someone from another culture. But make sure that people within the clinical setting understands that as well through whatever process they do that. I think there are people on the listen to this now in rural areas and wouldn't understand what I'm saying in relation to making sure that you understand and respect the individual and where they come from and their family. If you can't get support and information from them, ask another male in there if it's a male to male situation, or female if it's in that situation. But don't cross the genders when you're dealing with Aboriginal people. If you can go and not cross the genders, it'll be great. But if you If you can't, you need to work through that with the family and work out how you can best do that. But that's not for everybody. That's just something that I'd be looking at, for example, if I was working in a clinical setting. When I was involved with somebody who worked in the clinical setting all the time, they would not go near that at all. They would not go near that because they're not allowed to. So some people in our communities are not allowed to talk to men in relation to men's business, and men not allowed to talk to women in women's business. So we need to make sure it's gender specific and it's respectful and it's in a confidential nature. Yeah, we got screens, we pull the screen over and yeah, okay, but screens aren't soundproof. So we need to just make sure we have a process which makes people more comfortable within the setting.
Thank you.
And the only thing I'd sort of add to that is, yes, there's men's business, yes, there's women's business for all different people, but you know what? You're not going to know it unless you ask.
Yes.
And people will, whether it's body language or they'll tell you, might start posturing, putting their head down, uncomfortable, looking away. Bang, you've hit the gender business. So go get someone who, just
So
take
be
a bit of
observant.
initiative and be aware. I'm quite happy for men to engage, me and my health services above the waist and below the waist. There are some women, my age group, who are like, oh, no way, I'm not having men touch me above the waist or below the waist. So gender business is alive and well, but you know what? That's for most people in general. And I guess we're kind of hinting at looking at what is the best practice model. So it's about getting it right. If you get it right for Aboriginal people, I promise you 100% that it will work for your non-Aboriginal clientele as well.
Yeah.
Okay.
Yeah. Okay. Yep. Thank you. So it's about recognising cues. Yeah.
I just wanted to say that when we started the Aboriginal Health Strategy Team in July, August last year, and we're called on, as well as Nola said, that sometimes if there's no one around to support the patients, but there's a real risk and there's a fear that has been expressed by Aboriginal people who attend the hospitals, that if there is no understanding by the clinician on the culture and importantly what some of those protocols are for the man or the woman, there's a fear by that patient that they could actually be placed in a ward or somewhere else, or their care might be compromised because they're making a judgment or an assumption about what may be wrong because they may not be speaking the language that the clinician wants. So, and I think that individual responsibility by every health professional, especially the clinicians and especially the doctors, to have that understanding and to know what those businesses are so they can actually provide that respectfully and confidentially. So just to be aware about the consequences of that.
Yeah. Yeah. Any more questions, comments from the floor? No. We've spoken quite a bit along the way about health services, the systems, and funding, and definitely primary care. It's much easier to stop something than it is to fix it. So, yeah, well, you speak. Oh, sorry, I'm forgetting about the mic now. So, yeah, what are some of the reasons, this was a question that came in, and we have touched on this, that people don't attend follow-up appointments? Pass to Nola. Heard from Nola for a bit.
I'm actually going to expand on this because I think
Yes.
it's really, really important. I think that We've heard across a number of different elements this morning, engaging the client, the cultural context, funding health services and as such, individuals taking responsibility for their health care, the cultural context in relation to past history. I think there are some key things in relation to that when we're talking about the health service and about health to Aboriginal people. I think what we need to, and Christine said it, and she said it on a number of occasions this morning, so, I think there's some key things that's come out of the conversations today, is that individuals have responsibility around their contribution to overall care, whether it's us as Aboriginal people and what we prioritise in our healthcare or clinicians providing the care. Even when it comes down to funding, it's the worldview. People, and we've heard it, just some of the questions, which I have no problem responding to, is what's the understanding for Aboriginal people and their health perspective? What's the day in the life of an Aboriginal person? So there's still some context that actually are contributing to some of the decision making from people in many different spaces. So whether it's around models of care, whether it's around developing reportables for funding, what people's views are or priorities of their views in relation to how Aboriginal people are treated even. And so I think that there's an array of different things in that space that we all need to be mindful of when we're viewing material, resourcing, responding to funding, those types of elements when we need to be conscious of. So I think that they're quite critical, and what your contributions are in that space. Because I know that we do work in parties, working groups. We hold steering groups or information sessions. So what your contributions are in that space are going to be quite important moving forward. Did you want to expand on that? Is that what you were?
Yep, thanks. Okay, so I think transport's obviously a huge issue, and we all experience that in some way, shape or form. But also from some of our experiences is that we can have a number of patients that might have consecutive follow-up allied health appointments, which can pose an issue, particularly if they don't have transport or if they are an elderly couple or such like that. So I believe that this can be sort of resolved through, we all have those MDT meetings, so it is about coming together. You're talking about one patient. It's about, ensuring that we're all aware of that person's situation, their family dynamics, their living situations at home, and trying to accommodate to the best possible way that we can that suits their needs. So, we've had one last week that had, I think, 4 appointments, follow-up appointments, one day after another, which just, and she just couldn't attend any of them. So it was a way of, finding out how best we can support that and overcome that, because then it just creates these terrible situations and mindsets of people to say, yep, typical, these fellas never turn up for their appointments, but it is that they do have legitimate reasons. So it is about sitting down, having that conversation, discussing that at the MDT meeting, ensuring that we're aware of that person's individual needs.
Yeah, and all that. One of the key things we found in relation to people not attending their follow-up appointments, if it's 2 months, a month, 3 weeks, 6 months, whatever, we're assuming that people have got their follow-up letters at the address that they've put their address at. And sometimes that's not correct, because sometimes the people have moved. Sometimes the individual has moved to another place and the mail hasn't been forwarded, or things like that happen. So one thing is, don't assume that if you mail something out that it's going to get to the individual that it's supposed to get to. Rule number 1. The other thing is, we have other responsibilities within our family. Sometimes following, I feel great. I feel 100%. Do I need to go to my follow-up? I had one yesterday. I went to do it because I wanted to get out of the system, which is great. But the point is, that's the other thing. The obligation we have also in relation to our family and other things. Where else was I going? And the responsibility we have to other people. But the main thing is, I think, is don't assume that they got the mail. connect with somebody or a system within the process to actually go to that door, knock on that door, hand that information. And then look at if that person has gone from this hospital or hospital wherever you might be in Western Australia, is there a community care process here where the care coordinator can actually organise to pick them up, take them to the appointment, put it on their list. It's about getting the external people from out of the hospital, the primary healthcare networks, the 360s. Look at how we can connect them to that individual, the care coordinators and the outreach workers, so that they can actually support them in attending their meetings, attending their appointments. Because if we send something out, they're never going to get it. I work in Division of General Practice and Medicare Locals for ages. And we made sure that we went to everybody's door and followed up to make sure they got the information. If not, we go to 10 houses where we think they might be. And we find them. And we say, where can we meet you? Can we get a number? Can we get a number of somebody who knows your number? Just in case you don't answer your phone or you lost it that weekend. I lose mine all the time. But we need to make sure that we have backup plans. Because just mailing out stuff. I live in my own house. I just changed my address. I got a letter the other day to do a follow-up appointment. I work in this system. I lost the mail. But luckily, I'm registered and it text message. I got a text message, so I follow the text message. I did all that. If that was how it is for me, how is it going to be for laymen in the community? So let's look at how we can support that individual by working with the primary healthcare networks within that region. It would be great if they're care coordinated and they got a care coordinator and an outreach worker working for them, supporting them with transport and everything else to get to that appointment. It's all about working collaboratively, like Denise said earlier. Why aren't we all working together to make sure this patient journey is successful rather than bits and pieces of a jigsaw puzzle that, sometimes we miss a piece. But the most important piece is the person who has to go to that appointment.
Thank you. I'm acutely aware that the VC sites may fall out very soon. So, we'll take...
Yeah, so shall I just do this one? It relates to what we're talking about at the moment and what you're talking about, Ian, about working collaboratively and working in teams. And that people have talked about you need to have connection and you need to build rapport with people, and that happens in community, which a lot of people have talked about here. So this comes from the northwest. I'm up in the northwest and find that with all clients from all cultures, we will only begin to see our clients once they need our services. It is clear how important community connection is with Aboriginal people. Do you place importance on us as healthcare professionals being present in communities without being needed? And if so, do you have any suggestions or ideas on how to do this realistically within a healthcare model, keeping in mind our time and resources are stretched as it is?
To speak to that, we'll have to make it fairly brief.
Yeah, I mean, I saw that as a health community worker, just building those relationships.
Yeah, I think that there's a number of key things that I think that we've spoken about today. So I think it's how you present yourself in community. When you're passing people in the street, acknowledging them. I think one of the things that's very evident, our mob never forget a face. If they meet you and you've engaged them, when they see you down the street, no matter where they are, they'll actually say hello. So if you make an effort on the street, they'll actually, respond to you. And then when they see your face in the service, they'll actually respond and engage. And then they know that you actually wanted to take the time. So there's some key things, just really small. But even engaging in some of the activity outside work hours will actually build a relationship which will draw them into the service. So there's just some key things, and we'll feed out some things after funneling today to ensure that we meet some of that stuff.
Yeah,
Well, that's what
going
I'm saying,
out to the people.
Being involved
Yep.
actively. Yeah.
No, but if you don't make an effort to go to where their community is,
No.
Yep.
then you're not going to be able to engage. And
Yep.
the issues that I've been dealing with.
Just in response to that, I think that, and I've lived in community for a long, long time myself. I've come from community. What you're saying is very true. I don't discount that, but it's your involvement in community. You don't have to necessarily go to community. It's your involvement, how you actually engage outside that space. You know, do you participate in any of the NAIDOC activities that somebody's holding? Just some key things without having to, you know, because it's very difficult even just as an individual, even for an Aboriginal person off country to go to another person's country, faces challenges for us as well. So I can appreciate that that's difficult. So, you know, you can go and put it out there that you're new in that space and, you know, I'm here to help you. But it's how you actually do that, where you do those things. Do you participate in their activities? You know, if you actually make yourself available to be a part of the community, their community, they'll actually respond really well to that.
So I would like just to close by thanking Ian, Terry and Nola. Kerry, sorry, did I say Terry? Sorry, Kerry and Nola. And just respecting the resilience, the courage and the strength that they have shown, and the other Aboriginal people in the room to partake of this conversation. And I think it has come down to values and virtues, which is our common humanity. And it's down to respect and trust and mindfulness and listening and being collaborative. And every little step we take towards this will help. And I thank you all so much for today.
And lastly, I'd like to acknowledge all of the Aboriginal and Torres Strait Islander people who work in the health system. Yes, we do work and walk and live in two worlds. And let's keep the work going for our people to make sure that we can actually be that conduit to assist them in getting where we need to be.
We will now say goodbye to those at the VC sites, and for any Aboriginal people within the room, we will be having a debriefing session and we welcome you to attend. There will be certificates for your attendance sent via email and an evaluation form, and we really appreciate your comments on this and other events that we might run so that we can all learn more in this space. Thank you.